therapeutic endoscopy in the US in McGill University. Dr. Ahmed, please.
Thank you very much. I wanted to start by thanking KGA and the organizing committee for this lovely invitation. Actually, I just noticed the only gastrointestinal organ that is not discussed during this conference is the pancreas. So here we go. We're going to discuss the recurrent acute pancreatitis. And I'll try during this presentations to go over the term IRAP, which is idiopathic recurrent acute pancreatitis, and how to differentiate that from the recurrent acute pancreatitis. I'll go over the etiology of recurrent pancreatitis. Why do we need to go to know the causes of recurrent acute pancreatitis? The role of genetics, environmental risk factors, and the link between acute and chronic pancreatitis. I'll try to be short and concise, and I'll try to avoid the pathway of acute pancreatitis. And at the same time, I try to avoid the pathway of chronic pancreatitis because each two extremes will need whole different lectures. So to start with a couple of minutes about acute pancreatitis, as we know, is one of the most common causes for admission to the hospital. It has a substantial contribution to the healthcare morbidity, mortality, and health costs. And for any of us to diagnose acute pancreatitis, we need two out of three criteria, symptoms plus elevated pancreatic enzymes plus imaging to suggest acute pancreatitis. And I'm sure every gastroenterologist in Kuwait came across at least few cases with recurrent acute pancreatitis, some of them with known causes, some of them are idiopathic. So this is a case of a young man, 37 years old, who's a smoker of 15 cigarettes per day, 10 pack years. He has a past history of psoriasis, and he was admitted with a picture of acute abdominal pain. Pancreatic enzymes and imaging was suggestive of acute pancreatitis. However, on reviewing his charts, we noticed that this is his third presentation with acute pancreatitis that required hospital admission. So to start defining what is acute pancreatitis, at least you need 2 documented episodes of acute pancreatitis with resolution of symptoms in between these attacks. This is conditional in the absence of features of chronic pancreatitis. The incidence of recurrent pancreatitis is about 8 to 10 per 100,000. And as we all know, alcohol and smoking, gallstones and alcohol comprises 80% of causes of acute first attack of pancreatitis. When biliary and alcohol causes were ruled out, about 25% will continue to have recurrent pancreatitis. And this is the aim of this presentation. If you go over this chart, you'll notice that biliary and alcohol still comprises the majority of causes of acute pancreatitis, first episode of acute pancreatitis. And then recurrent acute pancreatitis, still biliary and alcohol comprises the majority, and then comes the idiopathic causes. So this table actually summarizes the prevalence of causes among patients with chronic pancreatitis. However, it's interesting to see that genetic risk factors plays an important role, which are commonly forgotten or overseen during evaluation of patients with recurrent pancreatitis. Common genes involved are PRES1, the SPINK1, the CFTR gene, and the CTRC genes. These are commonly involved in patients with recurrent pancreatitis, and sometimes we label patients with idiopathic recurrent pancreatitis without looking into their gene. So smoking is an important risk factor. This is a cohort of almost 500,000 population. It's a very large cohort. However, 1,000 of those 500,000 population had more than or equals to 4 episodes of acute pancreatitis. If you look at the details of this cohort, so this is 1,000 patients with more than 4 episodes of acute pancreatitis. Almost 2/3 of those patients were both smokers and alcoholics. And then almost 1/4 of these patients are only smokers, 1/4 are almost only alcoholic, and then less than 1/4 are none of them. So this gives you an idea on how important smoking and alcohol on patients with recurrent pancreatitis. Smoking is actually a well-documented and evidence-based cause of recurrent pancreatitis. So after the first episode of acute pancreatitis, the pancreas is expected to go back to normal with normal physiology and anatomically. About 24% of patients with acute pancreatitis will actually develop chronic pancreatitis. And of those quarter patients, of those 24%, half of them are related to related to alcohol, and the other half are idiopathic. So smoking, again, back to smoking and recurrent pancreatitis, it's the only independent risk factor that is well documented to cause recurrent pancreatitis. Smoking increases the risk of developing chronic pancreatitis by 25%, and the theory behind that is that there is reduction of bicarbonate secretion, which kind of make the pancreatic juices more thick, more viscous, and kind of more likely to obstruct the main pancreatic duct and hence causing acute pancreatitis. Similar factor to smoking is alcohol, of course. Alcohol is also common in Kuwait, and it's a common cause of recurrent acute pancreatitis more than you think. So the risk of development of acute chronic pancreatitis increases with consumption of alcohol more than 8 milligrams per day for a period of more than 6 to 12 years. The type of alcohol is not related. There was no evidence behind it. However, cessation of alcohol ingestion will definitely play a role in the restoration of normal pancreatic parenchyma back to normal. So if we go back to the genetics, we know that there are certain genes that are extremely commonly involved with recurrent pancreatitis. The CFTR gene is common, SPINK1, the T5 allele, the trypsinogene mutations, chymotrypsin C mutation, and the carboxypeptidase A1 mutations are commonly involved in causes of recurrent acute pancreatitis. And the little table below is the actual genome of the patient who had recurrent pancreatitis and was all negative. So this is a nice demograph on all the genetic risk factors that are involved in recurrent pancreatitis. So if you look at the bottom of the screen, you'll find the red color is the odds ratio on how likely those patients will develop recurrent pancreatitis. And it's interesting to see that some genes with a strong inheritance or penetrance are more likely to develop recurrent pancreatitis because it's a predominant gene. However, with certain other genes, you need certain genetic factors to cause the recurrent pancreatitis, such as smoking, alcohol, nutrition, and other factors. So you need genetic factors as not a sole cause of recurrent pancreatitis rather than multifactorial. It's the same story with IBD. We spoke about IBD is multifactorial and needed some stimulants from the environment. So same thing with recurrent pancreatitis. Autoimmune pancreatitis is an important cause of recurrent pancreatitis. And also there is a dilemma in the diagnosis of autoimmune pancreatitis. A very common mistake in Kuwait, we send IgG4 level in all those patients, and some of those will come up with a slightly higher level, and they are referred to us to rule out autoimmune pancreatitis. Just a quick background on what is IgG4. IgG4 accounts for less than 5% of the total IgG in healthy persons, and it's the least abundant of IgG subclasses and very limited role in the activation of the complement system. So it's important for you not to send a total IgG, only send an IgG4 level to look for that. And this table, I'm sorry if it's not very clear. However, the IgG4 level needs to be at least more than 2 upper limit of normal to diagnose at least type 1 of autoimmune pancreatitis. 60 to 70% of those patients will have more than 2 times upper limit of normal of IgG4, and this is exactly the opposite in type 2. Type 2 is a bit of a more challenging diagnosis. And this is a quick background on IgG4. A lot of patients with well-documented autoimmune pancreatitis, they have elevated IgG4 in certain, mainly Asian countries. They have highly elevated IgG4. However, this is less common in European countries where IgG4 elevation, even in the setting of acute autoimmune pancreatitis, is not elevated, which makes the diagnosis, again, more challenging. So this makes me wonder where are we in the Middle East among those population? Unfortunately, we don't have well documentation about that. Steroid therapy, when we're in dilemma and we're not sure if this patient has autoimmune pancreatitis or not, in the absence of histological diagnosis, some of those patients are getting started on steroid therapy. However, in case of clinical deterioration, and if your patients continue to have recurrent pancreatitis, then this is very unlikely to be autoimmune. Rethink of the diagnosis and think about idiopathic recurrent acute pancreatitis. Medications is a common cause of recurrent pancreatitis, and it's usually idiosyncratic. You know, we know certain medications that are commonly involved with recurrent pancreatitis. Some of them are very uncommon and idiosyncratic. They just cause acute pancreatitis out of a sudden. Commonly, furosemide, hydrochlorothiazide, some of the antihypertensive and antidyslipidemia medications, and you know, our commonly used medication, Imuran, is also a cause of recurrent pancreatitis. Recurrent acute pancreatitis, some people, they label it as a chronic pancreatitis. This is partially true. And why is that important? Why do we need to know if this is recurrent pancreatitis or this is an already established chronic pancreatitis? You know, because chronic pancreatitis is a completely different pathway. You need to manage and look after that patient differently than patients with acute pancreatitis. Because, you know, there is fibrosis of the pancreatic parenchyma. There is progression, you know, progressive of the disease, progressive nature of the disease in terms of endocrine and exocrine function. This can lead to pancreatic cancer eventually, or possibly deterioration of the quality of life, shorter life expectancy, and this is irreversible when chronic pancreatitis is established. So there's always a dilemma in the early diagnosis of chronic pancreatitis, and usually it is diagnosed in a later stage in the absence of proper assessment. So it's important to know how likely are those patients to develop chronic pancreatitis, and this graph summarizes it all. So this is a graph on all the population with recurrent pancreatitis and when did they develop the probability of chronic calcified pancreatitis. During the first 2 episodes of acute pancreatitis, those patients are unlikely to develop chronic calcified pancreatitis. However, surprisingly, you see after the 4th attack of acute pancreatitis, more than 50% or around 50% of them develop chronic calcified pancreatitis. So those patients, you know, need to be treated as a chronic early pancreatitis. Idiopathic recurrent acute pancreatitis, a study on almost 700 patients with at least 1 episode of acute pancreatitis defines the risk factor to develop chronic pancreatitis. Per episode, they mentioned that every episode of acute pancreatitis has an odds ratio of about 2.9 for progression to chronic pancreatitis. In patients with recurrent acute pancreatitis, the other independent risk factor for progression to chronic pancreatitis includes alcohol, and also the other risk factor is necrotizing pancreatitis as well. So severe acute pancreatitis. During evaluation of acute recurrent pancreatitis, it's really crucial to have this patient undergo dedicated pancreatic imaging. A lot of the time we see patients referred to gastroenterology because of idiopathic recurrent pancreatitis, but we noticed none of them had dedicated imaging such as CT, MRI, or endoscopic ultrasound, because those imaging modalities, especially EUS, will actually identify patients with early chronic pancreatitis, so you can follow the pathway of chronic pancreatitis rather than acute, and I can identify common causes such as microlithiasis, occult malignancies, or small malignancies. As we know, malignancies less than 2 centimeters are really hard to be detected by traditional imaging rather than by EUS, pancreatic divism, and choledochocele, and other causes of common causes of acute pancreatitis. So this is an image, a video of an EUS endoscopic ultrasound imaging of an old lady with recurrent pancreatitis. She's 10 years post-cholecystectomy. However, she continued to have recurrent pancreatitis, and she underwent endoscopic ultrasound, which is, you can find here on the top here, this is the common bile duct with multiple stones inside of the bile duct, and this is clearly the cause of her recurrent pancreatitis, and this was overlooked by her CT scan, which was done for the pancreas. So this lady, she underwent ERCP, all these stones were cleared, and she never developed pancreatitis after that. So the take-home message is that always consider if this patient has a true idiopathic recurrent acute pancreatitis rather than acute recurrent pancreatitis. You really need to refer those patients for genetic analysis. You really need to counsel your patient about smoking cessation, and you need to have a dedicated imaging on those patients before you label them with acute recurrent pancreatitis. Smoking and alcohol, don't forget, are independent and important risk factors for developing recurrent acute pancreatitis. Always keep in mind the role of endoscopic ultrasound. You know, you're welcome to refer those patients for us to rule out subtle changes in the pancreas before label them as IRAP. Do refer your patients for genetic analysis. You know, genetics play an important role in those patients, and watch for chronic features of chronic pancreatitis. Thank you very much.